biomarker in Alzheimer's disease. So first of all, who of you is involved in the Alzheimer's task assignment?
Niet echt een actieve groep blijkbaar.
Brain, okay, so this might be very important for both brain injury and Alzheimer's disease, and very interesting for the rest of you. So I'll try to take the title into pieces and explain it to you, and in the end come to the research paper. So first of all, Alzheimer's disease. Is anyone familiar with Alzheimer's disease? No one? I'm not asking if you're having Alzheimer's disease, because you probably managed to get it. More or less. Okay. So Alzheimer's disease is a devastating neurodegenerative disease that mainly affects elderly, and therefore age is the most important risk factor. As you can see, at the moment, most cases relatively are seen in Europe and Northern America, if you look at this inner circle. Within several years from now, especially in Asia and Central and South America, they will get a lot of new cases of Alzheimer's disease. Well, Alzheimer's disease is, as I said, affecting elderly people, and there are becoming more elderly people in those countries, and therefore it will become a more and more important issue, not only for health, but also financially, because it's causing a lot of economic burden. In countries like in the center of Africa, where the average life expectancy is 30 years, they're not concerned about Alzheimer's disease, but in other countries they will be. If you have a look at the relative costs which correspond to Alzheimer's disease in high developed countries, you'll see that this is quite high compared to low and middle income countries. If you then have a look at the costs in the United Kingdom, which are related to dementia, they're much higher than, for instance, for cancer and heart diseases and stroke. However, if you look at the money spent to research on Alzheimer's disease and on dementia in general, you can see that this is way lower compared to cancer. I'm not saying cancer is more important or less important, but there will be a great need and funding for dementia research to cope with this problem. So this could be an example of dementia or Alzheimer's disease. And there are several things in this picture. First of all, it's not by coincidence that the woman in this case has the strange answer on this question. Alzheimer's disease is predominantly present in women, so more than in men. This woman is sitting. People who suffer from Alzheimer's disease also have mobility problems. This is not often known. They not only suffer from cognitive problems, also from mobility problems. And, as is clear from this picture, cognition is impaired. If we could have a look inside of the brains of these people, considering this person is not suffering from Alzheimer's disease and this person is suffering from Alzheimer's disease, then it could look like this. What do you see? Just by judging the picture. Size, yes. Alzheimer's disease brain is shrinking. Not only literally shrinking, also the amount of neurons are shrinking, the amount of synapses, so contacts between neurons, are shrinking, and therefore those problems which we just saw are occurring. If we could make slices of these brains, we would see a lot of other markers for Alzheimer's disease, but I'll come to that later on. So imagine a normal brain as a mozzarella. So basically, it's fatty, it's nice texture, soft.
Maar dan is het dus wel goedkoper
which
naar
represents a
mozzarella.
normal brain. How would you represent Alzheimer's brain? Well, pressed by gorgonzola. There are depositions in. I'm not saying that you're having infections or something like that in your brain, but you have depositions in your brain which look a little bit similar to this cheese. And this is why the normal function of Alzheimer's brain is impaired. Dementia is not the same as Alzheimer's disease. There are several forms which are named dementia, but which are not the same as Alzheimer's disease. Therefore, there's a need for markers to distinguish between the different forms of dementia, and in particular, since Alzheimer's disease is the most predominant form of dementia, in particular for Alzheimer's disease. As I already said, aging is the most important risk factor for Alzheimer's disease, and there are two categories of Alzheimer's disease, the EOAD and the LOAD. And this is separated by an arbitrarily border set on 65 years. 65 years. Basically, everything which is before this age is called early onset Alzheimer's disease, and after this is late onset Alzheimer's disease. And there's one important difference. Basically, 40% of the early onset Alzheimer's disease patients, 40% of those patients suffer from familiar form of Alzheimer's disease, meaning that there is one specific gene responsible for the development of the Alzheimer's disease. It's not said that in the other 60% of the cases the genes are not involved, but it will be an interaction of genes and environment, and it's not specifically known which gene is involved. The late onset, only 5% is suffering from the familiar form, and 95% is suffering from the sporadic form of Alzheimer's disease. So two examples of genes which are known to cause the familiar form of Alzheimer's disease, which is in the end only accounting for like 5% or less of all cases of Alzheimer's disease, are the amyloid precursor protein. And as the name says, it will be a precursor of amyloid. And amyloid, I'll come later to that, is an important marker in Alzheimer's disease. On the other end, there's the presenilin 1 and 2. If these genes are mutated, you also have an increase in amyloid. In the sporadic form of Alzheimer's disease, most likely these genes and mutations in it will also be involved, but it will be more a combination of environmental factors and genes and different genes coming in the end to Alzheimer's disease. So this is when Alzheimer's disease was discovered. It was not named Alzheimer's disease at that point, but it was Alois Alzheimer who first described this case of this paper. She died in 1906. And she was really a long way on the dementia road. And as you can read in this text, she really didn't have a clue about what was happening in the end of her life. This was quite severe, and Alois Alzheimer decided to have a look inside her brain when she died. And it was at that point that he discovered that there are two important features featuring Alzheimer's disease. As I already said, the amyloid depositions on the one hand, and dead neurons on the other hand. At that time point, he didn't have another description than dead neurons and strange depositions in the brain. And this is still, these hallmarks are still used to diagnose Alzheimer's disease up to now. So, to summarize, Alzheimer's disease is the most important form for dementia in elderly. It's featured not only by memory loss, but also by other inabilities or disabilities. And the molecular features, which were first described by Alois Alzheimer, are these amyloid beta depositions and those hyperphosphorylated tau proteins. But I'll come to that later. The exact mechanism still remains unknown in 95% of the cases. So how is this amyloid beta deposition, how is it existing? So this is an example. This is a neuron. And in this neuron you have a type 1 transmembrane protein. This is called the APP, the amyloid precursor protein. It contains a fragment, the yellow fragment, which can be cleft off and form the amyloid. This is the APP. And as you can see, only at the C-terminus they are transmembrane. And this is the yellow part. So it's partially in the membrane and partially outside of the brain, as shown here. What happens in Alzheimer's disease? Well, normally, in normal cases, in 95% of the cases, and what's happening in your body as well, this protein will not be cleft. It will be cleft actually in the middle by a protein which is called alpha secretase. And then you're just breaking down the amyloid beta. In Alzheimer's disease, for instance, by mutations in the APP itself, or in the enzymes which are cleaving it, they can direct it towards more cleavage of the amyloid beta. So indicating that alpha secretase is not acting on that point, but beta secretase and gamma secretase are acting. And if you have a shift towards the beta-gamma secretase cleavage, you will have more amyloid beta. Amyloid beta is a very sticky protein, and it starts to aggregate. And it forms dense core plaques, which is attracting a lot of other molecular markers. And these are the amyloid, beta amyloid plaques which are featuring Alzheimer's disease on a molecular level. This is an example of an animal model, because we know that mutations in these genes can cause Alzheimer's disease. We often use these genes to mimic the disease in an animal. And here we stained for amyloid beta plaques in a mouse model. By the way, this is the hippocampus, learning center of the brain, and this is the cortex. It's a little bit different than with humans. The other marker, the hyperphosphorylated tau, is also marked, and it happens like this. Well, you have a neuron with an axon, a terminal, in which it's making contacts with another cell. And to get the structure of this axon, you need microtubuli. And microtubuli need to be stabilized with anchors. And these anchors are called tau protein. These anchors can be phosphorylated. It's okay if they're phosphorylated to a small amount. It's necessary to have transport from the nucleus towards the synaptic end. But if this phosphorylation is too much, as you can see, the yellow ones are the tau proteins. If they're phosphorylated too much, they will loosen the microtubule. These will degrade, and the hyperphosphorylated tau proteins will get strangled into a paired helical filament. And these were the dead neurons which Alois Alzheimer saw in his first patient. So actually, they're just insolvable remnants of neurons which died. That's why they're called ghost tangles. The rest of the cells are gone. So you have two markers, amyloid beta plaques and hyperphosphorylated tau, visible as paired helical filaments. And this is how you see it on the microscope. However, Alzheimer's disease, as you saw, can actually only be diagnosed post-mortem. So all people who are saying, well, or from who people are saying that they are suffering from Alzheimer's disease, they are suffering from probable Alzheimer's disease. Because Alzheimer's disease, by definition, can only be diagnosed post-mortem. So keep this in mind. How do, for instance, clinicians do diagnosis of Alzheimer's disease then, or probable Alzheimer's disease? Well, they use the DSM-4, the Diagnostic and Statistical Manual of Mental Disorders. It's already the 4th version, and they're currently working on the 5th version. And they claim several parameters which have to, and conditions which have to be fulfilled to suffer from Alzheimer's disease or probable Alzheimer's disease. Which are these conditions? First of all, you have to have cognitive deficits in memory, so learning and recall, and you have to have one of the following cofactors happening, like aphasia, apraxia, agnosia, or disturbances in executive functioning. So you have to have both. Moreover, the deficits should cause an inability in social and occupational functioning. So people who are having these cognitive impairments, they should be impaired in having their normal social and occupational life. So like cooking, some of these functions should be disturbed. There's another condition which has to be fulfilled. The third one is that the course has to be gradual, and the cognitive decline should be continuing. So it's getting worse in time. And there are some exclusion criteria. You should not have all these features due to other brain disorders which are diagnosed, or to systemic disorders, or medication, or deliria. So these 4 features are used to diagnose probable Alzheimer's disease by clinicians. An example of to judge whether someone is cognitively impaired is the mini-mental state examination. And these are just 30 questions, very easy questions like in which year are we, which season are we, what's your name, what's your husband's name, which day were you born. And if people do not manage to answer 26 correct answers out of 30, they are considered to be cognitive impaired. And depending on how much of these questions they is wrong, or don't know any answer on it, they are graded into mild Alzheimer's disease, normal Alzheimer's disease, what's in the name, and severe Alzheimer's disease. If you have severe Alzheimer's disease, you're not able to answer on it many questions. So the second part of the paper, which I will discuss later on, will be the point of the biomarker. You probably know already a lot about biomarkers, so I'll try to summarize it. You can have biomarkers for screening, for prevention, for diagnosis, and for treatment. All of them have different functions, and it's important to have, ideally, for each phase 1 biomarker. So this is the definition of a biomarker. So it's a characteristic which is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacological responses to therapeutic intervention. So it's a bit of summarizing the 4 aspects in which a biomarker can act on. And this is an example. Would be great to have such a one for Alzheimer's disease as well. But then you're not perfect. So what's the CSF? The cerebrospinal fluid. The cerebrospinal fluid is actually a kind of shock breaker which is around your brain and your spinal cord. And if you jump, you don't have a headache, you don't feel it because it's breaking the shocks. If you have a puncture, a lumbar puncture to get CSF, you have less CSF around your brain, and those people are often suffering from headaches. And this is because the shock breaking effect is gone for a small while. So this is an example of where your CSF is located. It's located in the ventricles and outside of your brain and spinal cord. And if you have a lumbar puncture, it's done around L4. So most likely you also heard about the blood-brain barrier. The general blood-brain barrier is considered every barrier between the brain and the rest of it. Well, basically there are 3 barriers. So you have the blood-brain barrier, which is on the level of the blood vessels in the brain. You have the CSF-brain barrier, that's on the level of the ventricles and the outside of the brain where the CSF is located. And you also have the blood-CSF barrier. So to make a scheme out of it, and in reality it's more complex of course, you have the brain, the CSF and the blood. The blood-CSF barrier is mainly on the level of the plexus choroideus, or the choroid plexus. The brain CSF barrier is at the lining of the ventricles where the ependymal cells are located. And then you have the blood-brain barrier, which is on the level of the endothelial cells and podocytes of the astrocytes on each capillary, which is present in the brain. So this is an example. Here you can see a blood vessel. You have the endothelial cells, and they have extremely tight junctions, different than elsewhere in the body, to prevent transport of toxins or nutrients which are not allowed in the brain to go into the brain. On the other side of the endothelial cells, you have the astrocytes, and they use their podocytes, their feet, as it said, to cover these endothelial cells. And they determine, together with endothelial cells, via, on the one hand, passive transport, and on the other hand, active transport, which compounds might cross the blood-brain barrier in either direction. So this is another view. And just to give you an indication, the blood-brain barrier is not just one blood vessel which is going into the brain and that's the blood-brain barrier. No, basically every neuron has its own capillary, so to say. So it's a huge amount of contact level between blood and brain, so there needs to be a tight barrier. This is the blood-brain barrier. to show the choroid plexus and the ependymal cells lying in the ventricle, which is generating the CSF brain barrier, and the blood CSF barrier on the level of the choroid plexus. Okay, last part of the title, the plant sterol brassicasterol. I know you will have a lecture from Jochen Blatt next week about plant sterols, so he will go more into detail on this, but I'll briefly introduce what plant sterols are. So basically, plant sterols are the cholesterol of plants. Plants don't have cholesterol, and animals or humans don't have plant sterols unless they take it by the diet, but they don't generate it themselves. Most likely, none of you will be able to discriminate the difference between cholesterol and plant sterols in this quick view. I'll go back, try to find the difference. It's not numbered. Anyone?
The side chains?
Indeed. In the side chain, you have on the 24th position, for instance, the campisterol, you have an additional group. And it's a methyl group for campisterol, and an ethyl group. So here, this is the ethyl group, this is the methyl group. When it's an ethyl group, it's called cytosterol. When a methyl group, it's campisterol. If it's a methyl group, together with a double bond on the 22nd position in the side chain, it's called brassicasterol. The double bond with the ethyl group, it's stigmasterol. The plant sterol of interest of the paper will be those four, and we'll focus in the end on brassicasterol, since this appears to be an interesting mark. So what's the difference between cholesterol and plant sterols? Well, cholesterol is synthesized in your body, and you can take it from your diet. Plant sterols will only derive from your diet. This is a huge advantage, because if you find a plant sterol somewhere, and you find a difference in concentration, something is happening with the transport or the diet. So there's no possibility of synthesizing or metabolizing it yourself into a plant sterol. Another important feature of cholesterol is that 25% of your free cholesterol present in your body is located in your brain. It's quite a lot, and it's necessary for insulating axons. But the cholesterol which is in your brain is not derived from your diet, because cholesterol cannot cross the blood-brain barrier. Plant sterols can, and this is an important difference. So, since they are able to cross the blood-brain barrier and get into CSF, and since they are only derived from the diet, so if you look into the brain, derived from your plasma, they can be an excellent biomarker if something changes within the course of the disease. So what happens in Alzheimer's disease, go back to the scheme. In Alzheimer's disease, you will get a fibrotic plexus, fibrotic choroid plexus, meaning that the transport across this plexus is disturbed. And this would mean that the substances which can be found in the CSF might be a marker for Alzheimer's disease. Why would plant sterols be a good marker? Well, they can enter, and they're not synthesized in the body. You also have other markers which could be looked at, but most of them are synthesized in the body as well, or are metabolized. Plant sterols can hardly be metabolized in the brain, because when cholesterol is metabolized in the brain, it's turned into 24-hydroxycholesterol. If you remember correctly, all plant sterols had on the 24th position a modification, so they cannot be hydroxylated. So they cannot be metabolized, so they'll stay there. They're basically inert. So this brings me to the title of my paper, the plant sterol brassicasterol as additional CSF biomarker in Alzheimer's disease. And you now already have some ideas where this will be going to. So our hypothesis was that plant sterols have difficulties entering the CSF in AD, because the fibrotic plexus is there, and therefore might be a good biomarker for early AD. So what did we do? We took patients which were diagnosed for probable Alzheimer's disease using the DSM-4, and we took a group of controls, non-demented controls, and we took plasma and CSF from these patients. I have to mention the control group are not healthy controls, they're just controls, because you're not going to take CSF from someone just because you like do a study on it. It's because it can cause some disabilities. So therefore, we used patients which went to the neurological clinic and were not diagnosed with cognitive impairment. So they might suffer from other things. However, things or diseases which might interfere with blood-brain barrier integrity or in the end, with Alzheimer's disease were excluded, like insulin-dependent diabetes, alcohol abuse. Those cases were excluded from the study. So we have two groups, Alzheimer's patients and age-matched controls. We also excluded people with a highly permeable blood-brain barrier. Someone an idea why?
Response, an immune response, which makes the blood-brain barrier more permeable.
Yes, this could be a cause of the blood-brain barrier integrity loss, but we excluded them because Alzheimer's patients with Alzheimer's disease or diagnosed with Alzheimer's disease, which are in a very late stadium, they have a very leaky blood-brain barrier. Most often it's thought that Alzheimer's disease patients always have a leaky blood-brain barrier. This is not true. Only 20% of the cases, and these are the worst cases of Alzheimer's disease, so they are quite cognitive impaired, and I can assure you then you don't need a biomarker to see that they are cognitive impaired anymore, so they are quite responding badly to the examinations. So we have a group with an intact blood-brain barrier for both Alzheimer's disease patients and controls. We also included in our model some risk factors, like age, gender, ApoE4, it's a lipoprotein mutation which is correlated with Alzheimer's disease, the albumin quotient to determine the integrity of the blood-brain barrier, A-beta and CSF, which is already used in some settings to diagnose probable Alzheimer's disease, and it's. Does somebody know what will happen with amyloid beta in your CSF in Alzheimer's patients? Will it be higher or lower? What do you think? 50% chance?
Low.
Higher? We say higher? Well, actually, it's lower. But it's a good guess, because you would expect it to be higher, because you're producing more A-beta. But on the other end, it's sticky, and it's going to collect itself, so to say. So you get depositions of A-beta, and therefore you will have less A-beta in your CSF. But it's a good educational guess. The tau, however, will be increased, because normally you have low levels of phosphorylated tau, but now the tau is dissociating, and it's only partially aggregating, but now it's able to get into the CSF. So another marker for probable Alzheimer's disease is an increase in phosphorylated tau. Then we also included plasma creatinine as a negative control, because we didn't expect it to interfere at any level with Alzheimer's disease. There were no indications, and I'll explain why we included it in the model. Well, we generated a model whether plant sterols in the CSF could be predicted by the risk factors which we knew, and we did a backward linear regression analysis. You don't have to totally understand how this is working, but basically it is checking which of these factors is contributing to the prediction of your plant sterol in the CSF. And if one parameter is not influencing or predicting the plant sterol concentration, it will be kicked out of the model. So for instance, so this is the summarized model. creatinine in all cases fell out. This was what we expected, and that's why it was a negative control. So it does not contribute to the prediction of plant sterols. So this will drop out. And we did this for every plant sterol. We checked which factors were predicting. And for instance, other factors fell out, like in some cases, the age didn't predict the concentration of the plant steroids. But in the end, you have a model with all predictors of concentration of your plant sterol. And if you put this model into a univariate analysis, into an ANOVA, you can compare whether these concentrations are significantly different between Alzheimer's and non-Alzheimer's patients. This was what we did. So we first generated a model in which only risk factors which are relevant were in, and then we compared whether this was different between the two sets in the population. So these are the hallmarks of the risk factors. So beta 1 is age, beta 2 is gender, beta 3 is ApoE4, beta 4 is CSF plasma albumin quotient, A beta 42, tau, and plasma creatinine. And then we did the multivariate analysis, as I said. So basically we were comparing, and in this case, X0 is disease or not disease. So you will determine whether the group, if this is a dummy variable, if this is influencing your outcome or not. And by this statistical way of calculating, you can compare between two groups whether the plant sterol is different in the CSF or not. So this yielded this information. For instance, for camptosterol, the covariates 1, age, 3, ApoE4, 4, CSF A beta, and 5, phosphorylated tau were included. So they were significantly contributed to the prediction of camptosterol. Then we compared in a model using only these variables to compare the controls to the Alzheimer's disease patients, and we found that there was no difference. Since cholesterol is often linked to plant sterol metabolism, we also correlated it to cholesterol. I think this is not really necessary because there are also a functional difference between plant sterols and cholesterol, but still we did it. And then we also compared it to the ratio. So if we only looked at the pure CSF plant sterol concentrations, we found that using the right parameters, that cytosterol and brassicatosterol were good biomarkers, and brassicatosterol was stronger than cytosterol in predicting Alzheimer's disease. So basically, we could use CSF to determine brassicatosterol in it, and then we could somehow predict whether this patient had Alzheimer's disease or not. And if we corrected it for cholesterol, that's why we focused on brassicatosterol only. Only brassicatosterol remained. So now you want to know whether this biomarker has a good predictive value. So you have to look at sensitivity, and sensitivity is the proportion of actual positives which are correctly identified, and the specificity is the proportion of negatives which are correctly identified, meaning that the S specificity is the number of false negatives. And this is plotted in a ROC curve. So it's a receiver operating characteristics curve. Basically, if your parameter is not predicting at all, it will be on the purple line. So it's just by chance that it is indicating something. It has nothing to do with prediction. However, if your specificity decreases, so it gets more specific, and your sensitivity increases, meaning that you're far away on the upper left of your purple line, the predictive value increases. Here you can see that brassicatosterol, if you calculate area under the curve, has 83%, and it's comparable to phosphorylated tau, and also going towards A beta presence in the CSF. So far, both A beta and P tau are models and used to predict probable Alzheimer's disease in some labs, some clinical labs. And our question was, will it help if we add brassicatosterol to this model? Now I'll come to that with the logistic regression analysis. And I'm not going to go into detail, but basically it's a model which estimates, if you have the model with only A beta and tau, whether it's better if you add resveratrol or not. And it gives an output which says you it's better or not. That's it basically. So we did this, and we found that basically the model which is incorporating resveratrol has a typo in it, is a stronger model than when you only use tau and A beta. So therefore, you can conclude that CSF resveratrol is an additional relevant biomarker in Alzheimer's disease. And I have to say, with what I didn't show so far, the plasma concentrations were equal. So the outcomes of the CSF were not influenced by the plasma concentrations. And this is a good sign because it means that it's a stable biomarker. So if you say it is an additional biomarker, somehow a clinician has to have a cutoff value to say whether you're above a value in risk or not. So we determined these cutoff values by putting the sensitivity on 85%. And for phosphorylated tau, this is 53.58 picograms per milliliter. For resveratrol, it's 105 micrograms per deciliter. And we also have a value for A beta. And by using these three cutoff values, if you're above this, you will have a good chance that you have Alzheimer's disease. And it's better when you look only at A beta and tau. So it's really helping. So these are these cutoff values which we determined. And as you can see, most of the patients are, of course, above or below this line, depending on whether you expect a decrease or an increase. Since we confirmed our hypothesis that resveratrol is less, it shows that it's quite a good biomarker. However, some patients still have quite high values of resveratrol. So therefore, the combination with the three of these markers is an optimization of the model so far. So the conclusion is that it is a good additional biomarker, not a sole biomarker, an additional biomarker. So why is resveratrol a good marker? It's exogenous. It's relatively stable in the plasma population-wide. It's predicted by the risk factors for Alzheimer's disease, and it's an additive value to the existing biomarkers. However, there's one remark I like to make. I don't know if someone from you is familiar with, for instance, B-cell proactive. Grandma, grandpa, mothers, fathers, putting butter on the bread. No one? Somewhere? Yeah? So it's containing planoma, enriched in plant steroids. Yeah? Okay, but this is quite a confounder. Because the amount of plant steroids in this butter, or the amount of like eating 300 apples a day. So you can imagine that this eating those spreads, those diary spreads, can modulate your plasma concentrations in the end. At the point that these samples were taken, those dairy products were not eaten that much. So if you would have somebody in the clinics and you would like to use plant steroids as biomarkers, please also take into account that you have to ask for dietary habits, because if they're eating like the amount of 300 apples a day in plant steroids, yeah, you might have an increase in the CSF in the end as well. So this is a critical remark which should be kept in mind. Furthermore, the limitations, as I already mentioned, diet. Another one is it's an early biomarker. So indicating that it's targeting early on Alzheimer's disease. But is that enough? Personally, I don't think so. I would like to know some years in advance, before I'm developing Alzheimer's disease. Well, I have a high chance of developing Alzheimer's disease within 10 years from now. What can I do to stop it or to postpone it? You know? So this one is already a marker when you're in the early stages of memory loss. So it's an early Alzheimer's disease marker and not the one which everyone is looking for, I think. And the other one is that the practical performance to measure resveratrol is at this point limited. There are only a few labs in Europe which are equipped to measure it. It's not difficult to measure it, but only few of the labs are equipped to measure it. And if you really would like to use it as a marker, more labs should be equipped with it. And therefore it should be confirmed in a larger population study. So the take-home message is for you, what is Alzheimer's disease? And so the ones who are the task assigned for Alzheimer's disease will tell you more about it in the end of the block. What are biomarkers? And also statistics might be important, so don't overlook it totally. They are important. And especially the interplay of these three players are important. So if you have any questions, I'm glad to answer. Yes?
You said it's an early marker
Yes?
for Alzheimer's disease. At the beginning, you also said people